Okay, let's move into talking about hemophilia. If you translate the word blood lover, it seems a little strange, but really we'll find that it's problems with blood clotting and therefore excessive bleeding, so they may require more blood transfusions than the average patient. Hemophilia is actually a group of disorders. There are various different kinds. So if someone says, I have hemophilia, well, you need to know what kind they have to know how to treat them. But they are all hereditary, so we'll look at some of those hereditary patterns. They're also similar in that they're all a deficiency of one of the clotting factors in the blood. Those are those proteins that help make up the plasma. They also help activate the platelets too. If you are having trouble remembering the clotting cascade that hopefully you discussed in anatomy and physiology, you can go look that up. But you'll find that there's this whole cascade, this whole step-by-step process of which factor needs to do what. And you can see that the different types of hemophilia have different factors missing. I only have the three most common listed here, but there are other kinds as well. So hemophilia A, you'll see, affects 80% of patients with hemophilia, so it's by far the most common type. It's also called classic hemophilia, and it's clotting factor number 8 that's missing. So number 8, that's pretty far up on the chain. Not much clotting is going to take place at all for this patient. Hemophilia B, it's also called Christmas disease because of Dr. Christmas, is clotting factor number 9. So it's a little bit better than hemophilia type A. You get a little bit more clotting that happens, but not much. And you can see that's about 15% of hemophilia patients. The last kind, hemophilia C, is less severe, and it's clotting factor number 11. So again, you have more clotting that can happen, but that is far less common. It's less than 5%. And then there's less than 1% of patients who all have various other types of hemophilia, but again, very rare. So 1/3 of cases of hemophilia are actually spontaneous mutation, meaning they're not inherited at all. But for those cases that are inherited, hemophilia C is autosomal recessive, like sickle cell disease or cystic fibrosis. So you can go back and review those inheritance patterns on some other presentations. Hemophilia A and B are both X-linked recessive, so this is more like Duchenne muscular dystrophy, if you want to look back at that one. Because they are X-linked, whether or not the patient has the condition is directly tied to what their gender is. So, like with any children, first the parents have a 50-50% chance. 50% chance it's a girl, 50% chance it's a boy. And then, for the girls, there's a 50% chance that they will be a carrier or not. And for the boys, it's a 50% chance between affected or totally unaffected. So let's look at the genes. Dad has a normal X and a normal Y. He gives the X chromosomes to the daughters and the Y chromosomes to the sons. So depending on which chromosome he gives, the family will either have a son or a daughter. The mother has 2 copies of the X chromosome. She has an unaffected copy and an affected copy. So the 50-50% chance she has here is, do I give the affected copy or the normal copy? For sons, she will either essentially be giving the son the hemophilia gene or not at all. So the son will either be affected or completely unaffected. For the daughters, even if she gives the hemophilia gene, the daughter also has that normal X chromosome from dad, so she's only a carrier, she's not affected. In order for a daughter to have the disease, dad has to have the disease, and mom is either a carrier or actively has the disease. For this reason, it is far more common to see boys with X-linked recessive diseases, and girls are just the carriers. Again, it's just like Duchenne. When we talk about hemophilia and Duchenne, we normally refer to our patients as boys or men, simply because it is far more common to have the men be affected rather than the women. So what does hemophilia look like? Well, frankly, it depends on which clotting factor is missing. So with hemophilia A, like I said, it's farther up the chain. We'll see more severe symptoms. And then down to hemophilia C, less severe. For any type of hemophilia, the symptoms don't usually appear until the child becomes mobile. Not that they don't have the disease, just that we don't see it. So think about this. For hemophilia, it's a problem with the blood clotting. So cuts, bruises, injuries, these are all going to be an issue. With a newborn infant, normally we wrap them up in a blanket and are very gentle and snuggly with them. Very little injury for these children. However, once they start crawling and falling and walking and bonking their heads, that's when we start to see the symptoms actually appear. So it's always easy bleeding, easy bruising. A couple of the more serious or dangerous symptoms that we see are hemarthrosis, where there's actually bleeding inside a joint. That leads to bone changes, joint damage, contractures, and then of course any kind of deep tissue or brain hemorrhage, it can be life-threatening. To diagnose any of the kinds of hemophilia, we can do genetic testing. We can even do prenatal genetic testing using chorionic villus sampling or amniocentesis. And we can also do laboratory data to actually see what level of clotting factor that patient has in their body. That can help us determine whether they have mild, moderate, or severe hemophilia. To treat any of the types of hemophilia, we essentially replace that missing clotting factor. For type A, the factor is called cryoprecipitate, and for B, they actually call it Christmas disease concentrate. They are always via IV infusion, and usually it's 2 to 3 times per week with an extra dose anytime there's an active bleeding episode. So these children are having IV therapy 2 to 3 times a week for their whole life. When they're really small, it's usually the parents who are administering the medication, but by about elementary school, these young boys are actually learning to do IV infusions for themselves. We just have to hope that they don't then take those IV skills and turn them to drug abuse or anything more dangerous like that. Like with all of the genetic diseases, of course, they're also investigating gene therapy, but so far there hasn't been much progress for hemophilia. Some things you need to remember as a nurse caring for these patients, you just generally need to be gentle and make sure to avoid any damage to any of the tissue in their body. That seems self-explanatory, but then as we start to go through some of these, maybe you'll realize you hadn't thought of some of the potential injuries. So for example, we are going to avoid rectal temps. Any kind of rectal trauma can lead to bleeding, which then might be very difficult to stop. Even the pressure from a blood pressure cuff can be enough to cause a deep bruise for a patient with hemophilia. Of course, we need to make sure the children are adequately vaccinated, but if possible, we will avoid IM and sub-Q injections otherwise. If they need an injection, we'll make sure the patient has had a recent bolus of that clotting factor first. Even tape, just tearing tape off of someone's skin, can cause bleeding under the skin. And for IVs, again, the factor replacement is IV, but otherwise we avoid that IV if possible. For blood sampling, if possible, we'd rather do a finger stick than venous puncture, simply because it's easier to get that to stop bleeding. And then, of course, no child will take aspirin, but even as an adult, these patients need to be avoiding aspirin because it just exacerbates that bleeding difficulty. We're also going to be doing a lot of assessment on these patients and close supervision to make sure they avoid injury. A lot of patients with hemophilia type A, at least, will actually have special helmets designed for them while they're learning to walk, since that's when young kids are more likely to fall and land on their head. We actually have them protect that head to make sure there's no intracranial bleeding going on. We also encourage our patients to maintain a healthy weight. Any extra stress from being overweight or obese on the joints just increases the likelihood that there will be a serious bleed into one of those joints. And then along with that, maintaining good range of motion and even some physical therapy exercise for those joints. I'm going to let you go ahead and watch the video here on your own if you'd like to see it. Basically, it just walks you through some of the non-contact sports that are available for boys with hemophilia, and even gets into some of the consequences if the boys choose to ignore the doctor's recommendation and do try to take up football or wrestling, for example. If a patient has an active bleeding episode, we treat it sort of externally and internally. So externally, we're going to apply pressure, immobilize the joint, elevate it, and apply ice packs. Maybe you've heard of the acronym RICE: rest, ice, compression, and elevation. That's exactly right. But we also if possible, would like a bolus infusion of that clotting factor. If we have the factor with us, we'll absolutely go ahead and do that. Otherwise, the patient might actually need to be transported to the nearest emergency room to have that factor administered. Of course, if it's an injury to the head or the torso of the body, then we have risk for cranial bleed or internal organ bleed, and so the treatment needs to be that much more prompt. I will go ahead and play this video for you. It's about a teenager with hemophilia and how he manages his disease.
This year, we are doing really well. You know, my teammates and I, we've been working pretty hard, and we're currently undefeated by any other team in the state. So we've really been sort of pushing it. So it's performance athletics. And it's been great to participate in that, even with my hemophilia.
The first couple of years were very challenging. We went to the emergency room, I'd say about 25 times in the first 2 years.
In the last couple of decades, life has improved for these hemophilia patients, and we expect them to live very normal lives and a normal lifespan as long as they have good management and can make appropriate lifestyle choices.
Skylar Lobdell is a high school junior who lives in Vermont. He's a strong runner for the school's cross-country team and takes advanced placement classes. He has plans to study marine biology when he goes to college. Skylar lives with a hereditary blood disorder called hemophilia. It can be life-threatening, but it doesn't slow him down.
You know, because there are different levels. There's mild, moderate, and severe, and I got severe, which means that I have less than 1% of the clotting capacity of a average person.
Hemophilia is an unusual disorder. It's now very treatable, and what it is primarily a bleeding disorder. So with hemophilia, the body is unable to make a protein that we as physicians and other care providers call a factor. And when you don't make enough of this factor, you don't make enough of the protein that helps you to stop bleeding.
The sort of obvious impression people get is if you get cut, that you're not going to stop bleeding. And so, you know, that's the obvious one. But then there's the second sort of component of that, which is if you hurt yourself internally, like a bruise or something like that, that also will stop bleeding, and though it doesn't strike people as obviously, that's sort of the more major one.
Internal bleeding can occur anywhere from their brain all the way down into their abdomens and into muscles and joints in their legs and arms.
Patients with hemophilia can experience a lot of bleeding in the joints because knees, elbows, and hips get a lot of rough use. They are often strained or bumped and bruised. Multiple joint bleeds cause damage that can lead to painful arthritis. If bleeding into joints is not well controlled, joint damage will progress, and the person may require surgery, such as an ankle fusion or joint replacement.
Fortunately, therapies have improved quite a bit. Skylar is an example of this. He is running cross-country, and he is able to maintain his joint health with the use of factor replacement and with the multidisciplinary teams of the physical therapists and the orthopedists to teach him how to maintain his joint health.
I have been lucky enough to have been treated all of my life, so I haven't had a whole lot of serious problems, and occasionally I get some pretty bad bleeds and whatnot, but mostly it's just an inconvenience. You know, having to infuse 3 times a week and whatnot. My hemophilia treatment center is Dartmouth-Hitchcock Medical Center, and I transitioned to going there when I was fairly young. I'm set up with my nurse coordinator, Laurel McKernan, who's just fantastic, and they have a whole hematology department, which is great. Hematologists, physical therapists, just everyone, great nurses.
In most cases, the treatment for hemophilia is the infusion of a clotting factor into the bloodstream. This is the protein that is missing in people with hemophilia. Without it, the blood does not clot. Like many people with hemophilia, Skylar uses injections of the factor as protection, or prophylaxis, against any bleed that could happen. Skylar's factor was infused by his parents through a Metaport, a device that was surgically implanted under the skin of his chest. Metaports are commonly used in young children when starting an IV would be difficult.
I got my Metaport when I was about 1, and I had it for 9 years. So in the 9 years, I got really used to it, and I didn't really want to let it go. But it's a big step towards independence, because with the Metaport, you have to take a lot of precautions.
Skylar learned to do his own infusions through a vein in his arm, and the Metaport was removed.
It is a huge step for independence, because you don't always have to, be relying on your parents to do the infusions.
He began to want to take control of caring for himself, and did a fantastic job at mastering that. So he became largely independent in the infusion process, I think by the age of 10 to 12.
Again, my great nurse coordinator set me up with one of Dartmouth's sort of child therapists, and we worked through, psychologically preparing me for this. And after a few sessions, I was able to be fairly comfortable with it, and started doing them on a regular basis and moving away from the port. Now that I've gotten fairly good at this, doing the infusions, and I haven't missed in quite some time, knock on wood, I have sort of taken to challenging myself to finding interesting places to do them in. This summer I hiked a lot on the Long Trail in the Green Mountains, and I did one on the top of Glastonbury Mountain, which was kind of cool. I was in my tent, and doing the infusion. I had originally wanted to do it on top of a fire tower, but it was really, really cold and windy, so I made the decision not to.
The protection and independence Skylar gets from infusing the factor himself has made it possible for him to participate in sports, which he loves.
It's been a great experience, and this is my 3rd year of running high school, and we have had, we've worked really hard, and there's not a whole lot of contact, so you don't really have to worry about bleeds. And as long as you're pretty smart, do infusions before races, because you want to be at the best clotting factor level you can be. Because even though it's not a contact sport, there's definitely a lot of strain on your muscles in running.
I think that by having at least a moderate level of well thought out physical activities, he doesn't feel confined by his disease, and he's physically very healthy. He's very strong. He's able to run quite successfully. His level of activity has improved his overall health. It certainly has improved his mental health, because he loves to do all these things.
He's a successful cross-country runner, and part of that success is because he's learned from the physical therapists and the nurses and the orthopedists how to protect himself, how to stretch appropriately, how to warm up, and how to cool down, so he can have a successful career as a runner.
Hey, how are you?
Pretty good, and yourself?
I am okay, thanks. How are things?
They're good.
Good. Any
At
issues
Dartmouth
since
Hitchcock,
we saw you last?
twice a year we have these sort of hemophilia clinics. We have a set of appointments with various sorts of doctors to check in on us, physical therapists, to make sure that we're doing okay.
Have you had any problems lately with your hips when you've been running?
Been pretty good.
Yeah?
And then we usually meet up afterwards, and we'll have sort of a group discussion. And we'll talk about hemophilia most of the time. They do a great job of sort of teaching us about hemophilia. Lately we've been playing Hemophilia Jeopardy, or Hemophilia Who Wants to Be a Millionaire, stuff like that. And then really all of the staff are very knowledgeable. So you can ask them questions about hemophilia and they'll know the answer, or if they don't, they'll find out the answer.
You do, if you have a daughter, you give it, because you only have one, and girls have 2 X chromosomes.
Yeah.
So you only get to contribute one, and the one that you have, obviously, is the one with hemophilia. So there's 100%.
And, we can talk fairly frankly with each other about our experiences with hemophilia and stuff like that.
I think it's nice for the smaller kids to interact with the older kids and also to hear about what they're doing. It's kind of scary for both the parents of younger kids and younger kids to know what are their lives going to be like, what goals and dreams can they have. And when you have real life older people with hemophilia there, you get a better sense that the world is wide open. We lead very normal lives now. Hemophilia is not in the forefront for us anymore. It is a fact of life and we contend with it, but it's really no longer the defining feature. And I think a lot of that credit goes to the treatment center for the types of support that they have provided to us that allow us to pursue all of our recreational and educational and vocational endeavors that we're trying to do.
Skylar is an amazing patient. From the get-go, he and his family have been very proactive about managing his disorder. He has not let it interfere with how he runs his life and how he participates in life. He's maintained a very positive attitude, and that positive attitude has helped him understand his disease and manage it and try to control this. I expect him to live a very successful, full, and active life.
I am extremely proud of Skylar. He impresses me every day.
Okay, I know that was a little longer than some videos we watch, but I really love several aspects of that. Of course, there's the whole interdisciplinary approach. You can remember perhaps that Skylar keeps talking about the nurse coordinator. That could be one of you guys in the future. There's a lot of market for that. Also, I like that they were talking about having the play therapist teach him how to use the infusion equipment when he was first learning to do it. Talking you through different sports they can play, reminding you that running actually helps maintain a healthy weight and healthy joints for Skylar. So if you skipped it, maybe you should actually go back and watch it. Otherwise, I'm going to leave the presentation here, and then I'll pick up with a final presentation about leukemia.